Great. Well, it's really lovely to see you all here today. And we're really excited to cover this topic, which we've heard over the last year is a really big issue for a lot of people in Oxfordshire, especially a lack of information about the menopause. So hopefully we'll fill in some of those gaps today. So we've got Lubna here from Oxford Community Champions, and she's going to share some of her lived experience of the menopause in conversation with Fatu, who runs the Oxford Community Champions programme. And then we'll hand over to Dr Katie Barber, who's the clinical lead of the Community Gynaecology service in Oxfordshire and GP and menopause specialist. So that'll be really interesting. And then we'll open the floor for anyone's questions to Lubna, Katie, or to Healthwatch. So Lubna and Fatu, over to you.
Thank you, and welcome everybody. It's a pleasure to join you, Healthwatch and everybody else, to talk about menopause. So I'm just going to be chatting to Lubna, who is one of the champions with the community champions. So I coordinate the community champions program at the city council, and we have a group of residents with lived experience across the city who come and sit in a steering group to look at challenges that they face in accessing health care service across the city. And they also help us with co-producing solutions to those barriers that they've identified. So just to give you a brief context to what we do as a team. So Lubna, welcome. I can see your camera is
Yes,
off.
hello. Yeah. Hello. My name is Lubna.
Yeah. I just want you to introduce yourself and then briefly share with us your experience of menopause. Because I remember when we had this conversation in one of the meetings, the word was unfamiliar. You did not know what menopause was. You were telling me about all the symptoms that you have or the signs. You mentioned a few, and menopause was ringing in my ears, but because I am not a health professional, I couldn't say directly that this was menopause, but I remember writing it down for you on paper and saying to you to go to the GP and speak to him about it. So yeah, I'll just leave the floor to you to introduce yourself and just share your experience with us. Thank you.
Yes. Hello, my name is Lubna. I'm from Iraq. I live in the UK nearly 23 years. And I talk about menopause. It's really, nobody tell me before about menopause. And I am really suffering. My body, my hormone, everything. No doctor, no nurse, no anyone tell me about anything. But when I go to community champion to meet people, I talk with Feddu, with other people. They told me you should go to the doctor to tell them about menopause. We need to say what I'm feeling, what my body change. Sorry about that. Yeah. And it's really hard. Who going to ask? Who going to explain what's going on? Because I am suffering. I'm shouting. Sometimes hot flash coming and go. No one tell me until, because I put coil my Rena like 5 years when I am age 50. I go to nurse to take it out. She didn't tell me about menopause, what's going on. I think because hormone, the coil, I put it in my body. This has happened to me. I need to take it out. Still, I take it out. Still, I feel hot. Come in and go. And Feddu, she told me I should go to the doctor to give me this something to put it in my body to make it good balance the hormone in my body, because this happened from menopause. And I feel sad about lots of lady, because I work with the refugee, with the African group, Iraqi group, lots of people, community I work. Nobody know about the menopause. I really feel sad about them, because I no need to go through what I I've been in, because it's really hard. I can't sleep. Still, I'm little suffering, much better than before, but still suffering because I have a lot of issue. All the time I go to the doctor, I told him my heart getting faster. I can't sleep. He told me your heart, it is fine. He didn't mention about menopause and what's going on. No sleeping. All this damage me, damage my brain, my family. Uh, they should tell me early, like when I age 40, they told me if anything feel like that, hot coming, flash, you feel upset, you shouting, like that, I can't talk. I can't take medicine or tablet or water. I go search myself after when I learn about menopause online, and they told me drink lots of water, do exercise lots, relax, fresh air, something like that. I teach myself. Nobody tell me anything. And I feel much better, especially when I drink water in the night, when I do exercise, gym, cycling, swimming. It's really helped me lots than medicine, because before I take lots of paracetamol, ibuprofen. When I go to the doctor, paracetamol, ibuprofen, all the time he say that. He didn't mention anything about menopause. Yeah, thank you.
Thank you. Thank you for sharing that, Lubna, with us. And in that experience, what do you think helped you whilst you were experiencing it? What helped?
We need to tell early the women to look after them body. Nurse, doctor, like a leaflet or anything. How quickly, I don't know what else they, you remember you told me you need to take this something to put it in the body to make balance the hormone. Nobody tell me anything. I wish tell the lady what is good for them body, because nobody, no one same hormone, same feeling. Some women, they don't feel anything. Some women, still I am suffering, but much better than before. We need to talk. We need to mention about menopause. My mom, she didn't tell me. My sister and my family, no one tell me about that. We need to talk. We need to tell early the woman before when they have this menopause start.
Thank you. Yeah, information is key, isn't it?
Yes, yeah,
I think in this conversation and the previous conversations we had, it was around people not even knowing what menopause was. We talked about language, didn't we? Like the word
yeah,
menopause in
yeah.
itself, and
Important.
you being a migrant woman, refugee, and language is a barrier already. I don't know whether you want to just say a little bit about that, how that made the
Yeah,
experience difficult for you and the communities that
yeah,
you support as well.
yeah, because nobody perfect in the English. You know, still they struggle, especially the people they come new, like a refugee, Salam welcome. They don't know English, and it's really hard for them to explain menopause. What is menopause? We need from them language like Arabic, Pakistan, Urdu, different language to support them, to help them. Especially we need to start from the community, because there is the women talk same language and they support each other, you know, from the school, from we start from there. Yeah, because the doctor, you have all lots of information about the woman, about the age. When the age coming like 40, we need to tell them, be careful, you're going to through for menopause, we need this, that, how we talk to them, because they have different, not everybody speak English. We are suffering for that. We need small leaflet to tell them, to send them in the mobile, our leaflet when you go to the GP to check. Yeah,
Yeah. Thank you, Lubna. And
thanks.
I'm just, I know we have 2 minutes. Just to wrap things up, what do you think helped you in your menopause journey? What helped? Do you
Yeah,
have family
yeah.
and friends, or did the doctor end
Family,
up helping?
family, no, doctor, no. No doctor, no nurse, no anything. Friend,
Yeah.
I hear about menopause from a friend. Online, I search myself. I drink lots of water, help me. I searched online. They told me to do exercise, fresh air. I look after myself and a friend. That's it. No doctor, no nurse.
Okay. Thank you so much, Lubna. That is
My pleasure.
that's
Thank
it
you for
from
all
me.
this. Thank you.
Yeah, thank you so much. I'm not a clinician, so we would allow Katie perhaps to touch on the clinical part of things, but my role was to support you to be able to share your story, because I think a lot of other women like Lubna are in our communities who are struggling in silence, and some of the barriers there is around information gap. For example, they just don't have the information, and when they have the information, perhaps it's technical for them or it's not in the right language that they understand. And I think we wanted to bring that out to showcase it as a challenge and to see how healthcare service can support, the ones that would not usually go and access services, the ones who really have the barriers there. So, our ethnic minority or minoritized communities, especially, and those women, I mean, this cuts across the board. We know that, but different women are impacted differently and they have different challenges. So we're really looking at those women who would really struggle to walk through the door, to walk through the GP surgery, the women who don't have confidence to go and speak to their doctors about symptoms or signs that they're facing. Those are the women we're talking about when it comes to menopause. So I'm gonna wrap it up here, exactly the 15 minutes. And thank you so much, Lubna, again, for trusting us to share your story with us. And thank you to Healthwatch also for allowing us to be part of this conversation. Thank you.
Thank you so much, Fatu and Lubna. That was so interesting and so insightful. And yeah, we're hoping that by having events like this and building on that, then we can prevent more women having that kind of experience. So yeah, over to Katie Barber now. Would you like to share your slides and introduce yourself?
Thank you. So I'm just going to bring my slides up. Hopefully this will work. Go. Bear with me. Medicine may be a forte of mine, but the IT isn't. Can you see that first slide?
That's
Yeah,
great, thank you.
You've all disappeared off my screen now, but I can see Catherine, so that's fine. So hello, everybody. Thanks for inviting me to be part of this really needed webinar about menopause. So I'm Katie Barber. I've lived in Oxfordshire my whole life. I grew up in a village in South Oxfordshire, and I went to university in Imperial College in London, and then came back to Oxford for the rest of my training. And I've worked in Oxfordshire, Buckinghamshire and Berkshire, funnily enough, as a GP and GP trainee. I have lots of different roles. I was an NHS GP in a busy practice in Didcot till about 3 years ago. I now lead the community gynaecology service in Oxfordshire, which is where every woman that has a non-cancer referral is referred through in Oxfordshire. So we manage an awful lot of menopause in that service for specialist cases. But I also run my own private clinic, and I'm sat in my private clinic today talking to you on this webinar. But I work across the NHS and private sector. I'm an accredited British Menopause Society menopause specialist. What does that mean? That means I've done an advanced level of training to be able to manage women with really complex menopause issues, pre-existing health problems, cancer, epilepsy, neurological problems, women where maybe their treatment isn't working, or women that need a little bit more time to explore what treatment options might be available for them. So I do that both in an NHS role and privately. I'm also a member of the British Menopause Society Medical Advisory Council. What does that mean? That means I'm involved in writing national guidance and information about menopause and education, and I teach and lecture up and down the country. So I work with lots of different drug companies. I do receive payment for that, and also from other educational support organisations. I train nurses, doctors, hospital doctors, consultants about menopause. I teach in corporate industry about improving menopause awareness within the workplace, and much, much more. So I just want to really talk about menopause. Lubna's really hit the nail on the head here in terms of how menopause can adversely affect women. I'm going to use the term women and female, but by that I mean anyone that was assigned female at birth. Women over 50 represent 26% of the global women and girls which is a huge amount of people living over 50. And actually our life expectancy is increasing. You can see from this graph on the top right that if we go back to the 1900, you know, our life expectancy was the average age of menopause. And in the UK, the average age of menopause is around 51. So if I wouldn't be here if we went back sort of a couple of hundred years ago. You know, we've had huge rates of maternal mortality associated with childbirth, and we've got huge advantages in living longer because we live more of our lives in peri and post menopause. In fact, a woman being born today is going to live at least half her life in peri and post menopause. We provide economy, you know, so it's really important that we aren't getting to that point in our life where maybe we've got loads of expertise in whatever arena we're in, and actually menopause prevents us maintaining our goals and educating young people, whether that's in a family setting, whether it's in a work professional setting. It's vital that we stay at work and functioning. And it's a huge cost to the economy in the UK when menopause affects women adversely. So what is menopause? So a bit easier to define in reverse. So menopause is when your ovaries have stopped working normally. And when you start producing eggs at puberty, you've got about 250,000 eggs. You're born with about 2 to 3 million, and they degrade over time, and you hit puberty with about 250,000. And then over our menstrual life, those eggs deteriorate and are ovulated. And when they've all gone, that's menopause. So it's menopause is essentially ovarian failure. It comes from a Greek combination of words, menos and pausos, menos meaning menstrual flow, pausos means cessation. And it's marked by the end of our period. So lots of women will think menopause is when periods stop. And actually, they're probably right, because that's when our ovaries are no longer working. But actually, most of us will get symptoms and changes starting well before that last period. And the average is about 8 to 10 years of symptoms before your periods actually stop altogether. Then you've got something called postmenopause. So we're defined as postmenopausal when we've had 12 months from our last period. But you'll then throw into the mix of hormone-containing contraception, pills, coils, implants, which stop our periods. So for a lot of women, you can't rely on your periods stopping because they may have stopped already because of your hormonal contraception. So that's where it's really important we think about symptoms and presenting if we have any concerns about how symptoms are affecting us. As I said, the average age of menopause in the UK is around 51. About 96% of us are postmenopausal by 55. So there will be about 4% of women still having periods and functioning fairly normally after 55. There's two groups we particularly worry about: women who are slightly early, between 40 and 45, and the real concern is women who have menopause far earlier, more than 10 years from that normal age, which is called premature ovarian insufficiency. And that's when menopause happens before the age of 40. And if you have lack of estrogen, which is the key hormone the ovaries produce, it produces all sorts of other hormones, progesterone and testosterone, but estrogen deficiency, loss of estrogen at a very young age, can really affect our bone and our brain and our heart function. So young women, we really need to get hold of and treat aggressively with hormone therapy unless it's not advisable. We're seeing a steady trend in HRT prescriptions, and I'm going to come on to what treatment options there are for menopause, because it's not a case of everyone should have HRT, but still relatively low. This is not all the menopausal women out there accessing help and advice. So lots more to be done. And again, Lubna touched on this importance of education starting very, very early. So if we look at the stages of menopause, in our premenopausal life, we have abundant estrogen. Every month, our ovaries mature a follicle, and if that all works normally, that egg is ovulated mid-cycle. If it's not fertilized and it's not achieved a pregnancy, the egg and the lining of the womb are shed and we have a period. And that pretty much goes on from puberty right through regularly until perimenopause, when sometimes we notice changes in those hormone levels. So we might start to experience symptoms of menopause, which I'll come on to, but also changes in our periods. We might get periods that are longer apart, so bigger gaps between our periods. They might be closer together, they might be lighter, they might be heavier. And then we have our last period, and then after that is post-menopause. And you can see we don't have zero estrogen. We still produce a little bit from other places, but the level of estrogen we're producing after menopause is very, very low compared with what we were producing when we were still having periods. Now, there's loads of symptoms. I could have filled 3 screens with symptoms, and I think this is where Lubna really hit the nail on the head. That sort of repeated attendance with doctors and nurses of something not being right. And I always encourage clinicians, doctors, nurses, when I'm training, is just to think about menopause. There are lots of women that will present after age 40 with a variety of different symptoms that often are difficult to tie together. So mood change, temperature changes, itchy skin, insomnia, fatigue, burning mouth, brain fog, angry episodes, joint pain. And your doctor often does loads of interesting tests, all of which come back normal. And they send you away and say, there's nothing wrong. And particularly if you're in perimenopause, where you're still having fairly reliable periods, this view of you're not menopausal until your periods stop, which can often be really dismissing. And actually, you can be in perimenopause and your symptoms can be really significant in perimenopause. You don't have to wait for that final period to have stopped to then get some support. So I always encourage clinicians just to think about, is menopause the diagnosis? If you see a woman over 40 particularly, lots of different symptoms and all the blood tests are normal, is this perimenopause? These are real quotes. I've quit my job. I can't stand up in meetings dripping in sweat. I'm not going to go for that promotion. I don't think I can do it. I'm so exhausted. I'm making mistakes at work with disciplinaries or, issues going on at work. I can't function. I lose my train of thought. Things aren't great. I'm stressed about my marriage, work, the children, absolutely everything. I'm a shouty mum and wife. I don't like being this way. Everything aches. I can't run anymore because it takes me too long to recover. These are real quotes from real women that I've seen. And actually, all of this can be better if women are given the right advice and treatment, if that's what they want to do. Here are some myths. So if any of these things are told to you, you can challenge them. My blood tests were normal. I'm not menopausal. Oh my goodness, that's my biggest bugbear. So doctors will often check something called FSH, follicle stimulating hormone. Our brain produces FSH, stimulating our ovaries to produce an egg every month. And when the ovaries have run out of eggs, the brain starts to produce more and more and more FSH. But that's only when the ovaries have completely stopped working. So FSH in perimenopause, when you're still having some periods, is often completely normal. Doesn't mean you're not menopausal. It just means that you've not gone through the menopause and you're out the other side. So normal blood tests usually are the way in menopause. I'm still having periods, so therefore I'm not menopausal, or I have to wait till they've stopped before I can get HRT. And this has been on letters I've had to my specialist clinics from GPs. I've told this lady she can't possibly be menopausal because her periods haven't stopped. No, she's just in perimenopause. Or that fear of, if I take treatment and then I stop it, all my symptoms are going to come back and I'm going to go through menopause again. Menopause happens. Any treatment doesn't mask menopause happening, doesn't delay menopause happening. Your menopause will happen whatever we prescribe, whether it's hormones or not hormones. What happens when you suddenly stop HRT is sometimes your brain goes, oh my goodness, that was estrogen and I've now not got any left. What on earth's going on? So we wean it off gradually. It doesn't mean you're going through menopause again. It just means we don't want that recurrence of symptoms. I can't have HRT after 60. I'm in my mid to late 50s. Maybe I just shouldn't bother. No, that's not true. We don't set a time or an age limit to hormone therapy. And there's still this myth that HRT directly causes breast cancer, which it doesn't. It may promote the development of breast cancer, but it doesn't create a breast cancer from scratch. You're not going to induce a cancer by taking HRT. Menopause is just about hot flushes. Well, no, I've shown you that symptom screen. There's so much more. And actually, a lot of women are wrongly diagnosed with depression and given medicine for depression when actually it's part of their menopause. I've had a blood clot or I've had migraine, so I've been told I can't have any estrogen. That's not true. It just depends on the type of hormone we give you. And HRT is just to make you feel better, and I don't have many symptoms. Therefore, I don't think I need it. And there's so much more. There's lots of benefits to HRT as well. HRT can actually help lower our risk of bone density loss, osteoporosis, that's fragile, brittle bones that break easily, and also lower our risk of heart disease. So how do we manage menopause? The first thing to do is think about how we function as individuals. It's a great stage midlife in saying, what can I do for really good optimum health going forward? Now, the difficulty at menopause is some of those strategies that you've previously employed become more difficult, and women often do gain weight in menopause, average of 10 kilos. So it's about 1.5 stone over their perimenopause, menopause journey. Try and keep your weight into a sensible, healthy range for you. Minimize alcohol, don't smoke ideally, and also minimize caffeine because that can be a real flush trigger. So lots of women will find if they drink lots of coffee or espresso or lots of strong tea, they get far worse night sweats and hot flushes. Make sure you do plenty of exercise. This is really good for your bone and your joints. So it's not just about managing menopause, but we really want to maintain bone density as we get older, and doing all that exercise regularly is key. You may think about herbal treatments. Just make sure if you're going to reach for herbal treatments, you discuss with your GP if you've got any known cancers, particularly breast, ovarian and womb, because it may not be safe for you to do this. And then a lot of my time is talking about hormone replacement therapy. This is giving you back the estrogen that your ovaries are no longer producing, and most of these products are plant-derived. Very effective at treating menopause symptoms, but we also have non-hormonal options. And I'm really saddened when women say to me, I've had breast cancer, I've told you can do nothing for this, when actually there's loads of choices. A really good website you might want to look at is the Women's Health Concern. And they've got this menopause wellness hub, which covers diet, lifestyle, nutrition, exercise, all sorts of different things. There's some great leaflets on there for you to have a read about and get lots of information. In fact, their whole help and advice section is brilliant. So where can I find out more? Well, I've put the Women's Health Concern website on here. I'm sure Catherine will be able to share any of the links later. There's also Menopause Matters, which is a patient support forum. Daisy Network is particularly good if you're worried about early menopause, so menopause in women under the age of 40. But the International Menopause Society has a variety of leaflets in different languages, which is really, really important in terms of giving you information in a way that you can understand. In terms of education, we're desperately trying as medics in the UK with menopause specialist interest to get menopause in schools. I lecture locally in Oxfordshire to primary and secondary schools and teach the staff. I have 2 daughters who are nearly 11 and 14. And my wonderful teenager a few years ago in year 6 at primary school, when she was learning about puberty, said to her teachers, this is all wonderful, but are we going to learn about what happens when our periods stop? Because my mummy looks after ladies in menopause and says that's just as important as puberty. So go Emily on the advocate for menopause. But it's really important that young people understand about menopause. 1% of women below the age of 40 will have menopause prematurely. That's huge numbers. So we don't need to just talk about this when we get to 45, 50. We should be talking about it early and increasing that awareness. It should be talked about in the workplace. So I do a lot of work with organisations in terms of supporting women who are menopausal. We want women to maintain their ability to work, and actually working through menopause is key, but you may need some adjustments. Have a look at these different websites, have a look at the different languages, talk to your GP. Your GP is your first port of call. Now, as a hint and tip, because I can hear from Lubna that it was really difficult to get the right advice, the best people to ask, who should I go and see about symptoms, is the receptionist. The receptionist will know exactly who in the practice has a special interest in menopause, usually because they've asked that person already about their own menopause. And it may not be your GP. It may be your practice nurse. It may be the physician's associate. It might be the medical student or the training GP that's attached to the practice. And often it's an information gathering exercise. So have a look at the websites, use the tools and questionnaires that we're going to talk about this morning in terms of looking at the different symptoms you've got. Go with a list. Say, do you think this could be menopause? And if you're really getting nowhere, get a second opinion. It's fine to ask 2 or 3 different people in the same practice for their thoughts. Talk to your employer, talk to your family, talk to your friends. I know in some communities that may be more difficult, but please speak to somebody that you feel can advocate for you and get that support. Often shared experiences are really positive, so knowing someone else is going through the same thing as you can really help in terms of you getting the right support and education. In the community gynae service, but also in the secondary care menopause service, we use a lot of interpreting services. So I'm familiar with Language Line. I've had some amazing consultations with refugees via Language Line. I'm absolutely in awe of the Language Line staff, because the empathy they can put across during consultations, translating what I'm saying to the patient and what the patient is saying back to me, is incredible. So if you don't have someone that can interpret for you, that you may want to take a friend who can interpret for you, and that's absolutely fine, but sometimes it's not appropriate to take a family member. You might want to talk about personal things. You might want to talk about sexual function, intimate symptoms, and having a family or friend there is entirely inappropriate for you. It might be fine. It might be someone you're really happy to share things with, but actually that's where we use interpreting service, and it works really, really well. Ask for that. In the community gynae service, we give you slightly longer. We give you a double appointment, so you have up to an hour so that we can take time with that interpreter. Now, not everyone needs to come through my community gynae service. Most patients with menopause issues can be safely managed in primary care. But if you've got complex issues or you need a bit more time, or perhaps you need that interpreting services, that's when community gynae really comes into its own, and we can offer that extended time and support for you. I've put on here a symptom checker from the Menopause charity, which is absolutely brilliant. You can see there's lots of different symptoms in here, and sometimes going with this to your GP practice, whether it's the nurse, the pharmacist, or the GP, is really, really helpful, because then it sort of gives them an idea of whether your symptoms could be menopausal. As I said, ask for translation services, but also ask for information to be sent through to you after the consultation. In community gynae, we often send women entries. So we'll send exactly what we've written in the notes to the patient with links, and I can attach patient information leaflets. I can attach leaflets in different languages, and it allows you to have that time to digest the information. It's okay not to make a decision then and there about what treatment you may want. You might want to go away and ponder that and have a think about it before you actually start some treatment. It's okay to do that. And again, you may want to have time to assimilate that in a language or a way of writing that you feel comfortable with. So when might you need to see somebody like me? Really, when things aren't getting better, or you've had really early menopause, the recommendation is women under 40 should be under the care of a specialist. Anyone that's had a female cancer that could be hormone driven, like breast, ovary, or womb cancer, would normally get referred through to me. Or someone with a cancer where they're not sure whether it's safe to use hormone treatment. Women who have breast cancer genes, BRCA, BRCA genes, and genetic issues that might put them at higher risk of breast or ovarian cancer are often managed by specialists. And if you've got complex medical problems like heart disease, stroke, blood clots, epilepsy, you may be referred through to my clinic. And ultimately, if your GP is not sure, they have that option to be referred through. This is how things work in community gynae. So your GP refers you to us, and we generally look at referrals within 48 hours. So it's quite a quick assessment. Sometimes we're seeing women who need complex gynecology input, like fertility or like ovarian cysts or prolapse, and we may refer them straight on to secondary care. But actually, we can then assess you in the service with either telephone assessments or face-to-face assessments. So if you are going to your GP and you need a referral, please say if you need interpreting service, because what we tend to offer then is a face-to-face assessment in a double appointment. So we've got time and we can actually get that interpreting service organised for you. Now, depending on where we see you, we can upgrade to an urgent care 2-week wait referral if we think there's something sinister going on. We can discharge you back to your GP with advice, or we can manage you within the service. It's working really well. Menopause calls at the moment, within 8 weeks, we're speaking to somebody about complex menopause issues, which is a great waiting time compared with how it used to be. So that's the end of my presentation. I hope I'm all right for time. I'm happy to take questions, and I'm sure everybody will be as well.
Thank you so much, Katie. There's so much information there. We have had already a question in the chat from Katya, who's asked, how much do we know about associated cancer risk post-60? How high is that risk? And that was what their GP was really stressed about.
Yeah, the age you are when you take HRT is kind of irrelevant in terms of cancer risk. The cancer risk, breast cancer risk with HRT, relates to the duration of HRT, so how long you're on it for. So when we look at the studies about breast cancer risk, women who use HRT for less than 12 months do not significantly increase their breast cancer risk. And every year after 1 year, the risk starts to rise. Having said that, there are combinations of HRT that have a lower breast risk than other preparations. But really, for most women under 60, 5 to 10 years of HRT, we're talking benefits outweighing risks. And really, in women over 60, we don't say you must stop it. For some women, the quality of life achieved from using hormone therapy outweighs any small risks. And it depends on the type of HRT you use and how long you use it for. So I see a lot of women over 60 in my menopause specialist clinic because GPs perhaps not confident about the safety and explaining risk to patients, and I'm more than happy to speak to people in that service if needed.
Yeah. We've got another question in the chat. I was going to say to everyone, if you have a question, feel free to raise your hand using the hand function in Zoom, or write something in the chat, or you can just unmute yourself and ask a question. So Victoria has asked, what happens if you have too much estrogen in your body? What can help to balance the symptoms?
Okay, so generally in menopause, you're going the other way. You have too little estrogen. There are some women who are prescribed, not for the right reason, excessively high doses of HRT. The concern we have with that is symptoms. So you can actually, if you give too much estrogen, you end up with your symptoms coming back. So you get worsening flushes, sweats, palpitations, nausea, headaches. The way to balance is to bring the estrogen dose back down, but there's a concern with too much estrogen also about the safety in terms of your womb. So too much estrogen potentially can increase the risk of womb cancer if you're not using an appropriate progesterone or progestogen dose. So it's not about balancing the symptoms necessarily. It's about making sure that your estrogen and your progestogen dose are proportionate and that you give the right dose of each hormone and not use excessively high levels of estrogen. Most women in menopause need a modest dose of estrogen if they're going to take HRT to improve well-being. And the other thing to say is women who've had breast cancer, where we would not recommend using estrogen because of the risk of the cancer coming back, there are lots of non-HRT options. So we use non-hormonal options to treat flushes, sweat, sleep, mood, joint pains. And they're really effective. I think sometimes women look at me like I'm slightly mad when I offer a treatment that's often used to treat another condition, but there's clear evidence about these treatments being helpful to manage menopause symptoms with cancer patients. And I think they're the group I really feel are often neglected because there's that lack of awareness about, oh, you can't have HRT because you had breast cancer, therefore there's nothing, which is so incorrect. And when I see women and they say, okay, I'll try something, I think they think they've been told there's nothing. They come back at 3 months with a massive smile on their face. It's like, this actually works. My quality of life's better. Yes, it's never going to be as good as HRT, but if you can start sleeping a bit better and you're not having 10 flushes a night and waking up to pee every 5 minutes, it's much, much better and more effective.
And I think, yeah, that emphasis on the quality of life is so important from what we've heard from people. Does anyone else have a question?
Yeah, I've got one. In terms of the diverse community, there's a lot of people lack understanding of menopause. How do you think that that could be improved?
Yeah, it's interesting. I was talking about this the other day with my community gynae team. So we're thinking about how we improve education in these different communities and actually putting in sessions within the communities, whether it's in community centres or schools, to try and increase the awareness. Because I think that's where it's really important. We have sessions that focus on groups that maybe not accessing menopause care so effectively. I mean, typically white middle-class women are very vocal and will access healthcare, not always, but generally access healthcare very effectively, and particularly with menopause. And social media has done an awful lot to highlight the importance of menopause. But again, the advice on there and the information can be very confusing and often not accurate. So it's really important, whatever community you're in, that you actually access the right treatment that's evidence-based, safe and effective. So, you know, in terms of what we do in community gynae, it'd be good to keep the conversation going about how we can improve that. And I'm sure you'll be able to help us in terms of identifying areas that we could really get the education improved, and also what kind of sessions would work with feedback from those communities about what they would like.
Sometimes with the communities can teach each other as well, you know, what's happening. Like, you know, social media, yeah, there's a lot of people who go to social media, the websites, and it's real people talking to people, their experiences on how things can be improved as well.
And that's why having sessions like this, where you've got someone like
Oh,
Lubna
yes,
sharing her own experience, is really key, because it's that
absolutely.
understanding of what barriers did I face and what challenges did I have. And just as a mum of 2 daughters, I think it's really important that we think about that family unit as well. I mean, I've hopefully educated my 2 children about puberty and menopause pretty well. And, you know, around the dining table, we have quite diverse conversations. But that's not true of all families. You know, there are cultural differences in how we communicate about health awareness, and I think we have to be very mindful of that. But I think as medical professionals, we should understand the sensitivities and diversity around how information is shared and understood. And, you know, certainly in the consultations I have, I'm constantly looking for reflection of the information I've given and making sure it's been understood, and if it's understood, and if it hasn't been understood, why, and what can I do to improve that awareness. This is not easy in 10 minutes as a GP. And when I was an NHS GP, I ran so late.
Thank you.
Yeah, thank you. It reminds me of something that I think Lubna said to me in the past about also the importance of communicating to men and people who aren't going to experience menopause, so that your husband understands why you're being angry, or you have a lower sex drive or whatever it is, then that conversation beyond the women in our communities, that's really helpful. And we've heard from Emma in the chat who's said she's a social prescriber for a GP practice and would really like to do some outreach work in the migrant community. So that's also like another avenue for reaching people is through social prescribers and those like really key people doing non-clinical but crucial health work in our communities. We've got a question from Carla. So how do you know if the dose of HRT is the right one? And once you've started HRT, like when do you phase out the treatment?
So if you're having menopause at a normal age, and we would say normal menopause is any age after 45, and you've got symptoms, improvement in the symptoms is what gauges the dose of HRT. We don't do blood tests or anything like that to look at the dose, because actually improving your symptoms, and particularly if you have hot flushes, that's usually the easiest thing to get right quickly. If we eliminate your hot flushes, we know that the estrogen is being absorbed effectively and it's the right dose for you. The tricky thing is often younger women. So a lot of the young women under 40 are diagnosed with menopause when they've been maybe referred for fertility treatment, and it's an unexpected diagnosis, and they may be symptom-free, in which case there's some guidance in terms of what we use that's associated with an effective dose to protect bone density and heart disease risk and dementia risk. So it's a bit more nuanced in those young groups. But actually, once we get you on the right dose, sometimes it's a case of, shall we try weaning it? And a lot of women will say, look, maybe wait till 51, 52 before you think about weaning, because by then we can be fairly sure that you will be in that postmenopausal age, but not always. It's a bit difficult to predict, but it's really driven by the woman. So, a woman that's 52 and working may say, actually, I don't want to stop my treatment yet. Can you give me a bit longer, because it's going to affect me if this doesn't go well? And we do it really gradually. So you should, wherever you're looked after with your menopause, if you're on treatment, be seen annually as a minimum. So even if you're beautifully controlled with your HRT, you should be having a healthcare professional talk to you once a year. And that's an opportunity to say, how are you? Are your symptoms controlled? Because what you start on for menopause in maybe your late 40s may need adjusting. You may need the dose changing as you transition through menopause and your own estrogen levels fall further. So what you start on isn't necessarily the same dose you're going to be on forever. But also it's a great opportunity to say, right, now you're 54. How are you getting on? Have you had any bleeding? Have you got any symptoms? What's going on in life? Weaning HRT when your son's about to get married and your mother-in-law's really poorly because she's fractured her hip are not great times to wean HRT. Let's get to the point where everything's pretty good, and then we can give you a really slow regime. Don't stop HRT abruptly. Wean it off slowly with medical guidance, and then often things are okay. There are a very small group of women who won't function and need to continue longer term, but it's very much an individualized view. You shouldn't be left on treatment and no reviews. You should be being reviewed regularly, and that's whether you're on hormonal treatment or non-hormonal treatment.
Thank you. That's really helpful. Actually, wondered if you could say something in the research we did last year on women's health services. We heard a bit about surgical menopause, and I wondered if you could say something about that and any advice for people who might be about to go through that.
Yeah, so surgical menopause is where we remove the ovaries. Now, that can be for cancer or non-cancerous reasons. So it can be because of things like ovarian cysts or endometriosis. And essentially, if you are not already menopausal, so say, for example, you have an ovarian cyst and you're 59 and you had menopause at 50, surgical menopause usually doesn't adversely impact you in terms of hormones because your ovaries were no longer working. If you're in menopause, having menopause symptoms, removing your ovaries can often make your menopause symptoms much worse, because one minute there's a little bit of estrogen and the next minute it's all gone. So often if you're already on treatment, it may need to be adjusted. Surgical menopause in really young women, which does happen because of endometriosis or cancer, produces an abrupt, pronounced menopause. So one minute you're going along beautifully with lovely levels of hormone, then it's all gone. And those younger women really, really struggle because they've had an abundance of hormones that have suddenly been withdrawn. You should, in those scenarios, have a plan in place before you leave hospital in terms of, can I take HRT? And often it is a yes. How long should I use it for, particularly if you've had an early menopause before 40? And when do I need to be reviewed? You shouldn't be discharged from hospital without that plan, because usually within about 48, 72 hours, the flushes have started and you feel absolutely wretched. So surgical menopause, particularly if you're not already menopausal, can produce quite extreme symptoms. And actually, in women who have surgical menopause and their ovaries removed, sexual symptoms can be far worse. So loss of libido and impaired sexual function, reduced orgasm arousal can be worse because of our ovaries producing quite a lot of testosterone. And when that's suddenly withdrawn, that sexual function reduces significantly. So conversation's really important. I hope, when I was at the John Radcliffe leading the menopause clinic there, we had a leaflet that we used to produce in lots of different languages that were given to women with surgical menopause. And there was education about the gynecologist making sure that there was a plan in place, or sometimes I would speak to women before they underwent their surgery to make sure they had a plan in place, but often that doesn't happen. So again, that's a conversation that should be happening. You know, I'm young, I'm going to have my ovaries removed. Do I need to be worried about menopause? I would hope in an ideal world the healthcare professional should do that with you without you having to ask, but you know, be empowered and ask those questions.
Thank you. Yeah, that's a good motto. Be empowered and ask questions. And on that note, we have got some other comments. Victoria, it's not a question, but said it's very hard to find a woman gynae professional in Oxfordshire. I don't know, Victoria, if you're meaning sort of in terms of specialists or in terms of finding like a female GP who you can talk to about these things.
I would say there's quite a lot of female gynecologists at the John Radcliffe. I'm not intentionally, but the whole of the community gynae service is female. Every single doctor working in the service is female, and we have 5 menopause specialists now working in the service.
Yeah, and I think if it's at the GP level, then that advice that Katie gave earlier about talking to like the patient care navigator, receptionist at your GP practice about who the best person is to speak to can be a really good route to make sure that you're speaking to someone who'll be able to understand and point you in the right direction. And Katie has asked, what's the sort of strict definition of HRT? So is it anything with hormones, like estrogen cream, or does it have to be like a specific kind of medication?
Yeah, so it's interesting. I've just been at the European Menopause Conference in Valencia a few weeks ago, and outside of the UK, so Europe and America, Australasia, they use the term MHT, menopause hormone therapy, because hormone replacement almost suggests that you are replacing hormones that should be replaced, but actually you can manage without these hormones if you want to after menopause. It's not imperative. I like the term hormone replacement because we are replacing hormones, because the lack of hormones is affecting quality of life. And I think menopause hormone therapy starts to get a bit confusing. There's a lot of debate going on internationally about the terms we should use. Essentially, hormone replacement therapy is giving hormones that improve well-being. So this is, and protecting bone and heart and brain. So this is tablets, gel, spray, patches. Estrogen cream and pessaries do fall into that remit as well. It's giving you the hormones back that your body's not naturally producing. We would refer to creams and vaginal treatments as topical HRT, so estrogen applied locally to specific areas where those symptoms are abundant. And if you're thinking about estrogen gel, patch, spray, tablets, it's more of a systemic HRT. It's being absorbed into your bloodstream, where its benefits are working their magic everywhere rather than just locally applied in the vulva or the vagina.
Thank you, that's really helpful. Got a couple of other comments in the chat. So Emma said that there's a Muslim GP with a focus on women's health and menopause care who has quite a presence online. So that might be someone, Dr. Nigat Arif. So that might be someone people want to look up.
Yeah, she's fantastic. Yeah, really, really good. She produces some fantastic social media reels that are just hilarious. She's got the dancing to music and giving medical advice thing off to a T. She's absolutely superb.
Oh, nice. And that could be a really good way to share with other people in your community as well. It's a bit more engaging than some of like the very wordy leaflets sometimes, I think. And Victoria said, yeah, she prefers to see a female professional with some of these things, which is really understandable, I think. Can feel quite awkward explaining some of the symptoms to anyone, and particularly maybe if you're talking to a man. And Victoria, you can ask to see a female health or care professional. Sometimes it might mean you have to wait a bit longer, but if that's your preference, you can ask.
I think the other thing about that side of things is if you have seen a male professional who doesn't know the answers, any healthcare professional, whether they're male or female, if it's something you're not really confident in managing, you shouldn't, as a healthcare professional, be frightened to say, I don't know very much about this, but I'm going to ask someone who does. You know, I do a lot of women's health, and that's my special interest. But if you come and see me with something cardiological or neurological, I know quite a lot as a GP, but I don't know everything because GP's a generalist. And I'll say, actually, this is above my understanding. I'm going to go and ask someone for some help with this. And actually, I think as doctors, perhaps sometimes we're not great about doing that. Perhaps we're not great about saying we don't know, we're going to go and ask for help. There's an assumption that we should be able to fix everybody at the first contact. So don't be frightened if your GP says, I'm not sure, I'm going to go and ask, because in practices, they often have great lunchtime meetings where they talk about complex cases, or they look for advice from each other. You know, as a women's health specialist, over lunchtime, I used to frequently get grilled about what do I need to do about this lady's menopause, or can you tell me what contraceptive pill might work really well for this lady because she's had this side effect with that one. So you're utilising that expertise within practice, and that's really important.
Thank you. That's really nice to hear about as well, because we, you know, as patients and service users, we don't always see that side of things. Any other questions from the room? I wondered if, Lubna, I don't know if there's anything final you want to say, having sort of heard more about the services and the advice.
Yeah, we need to support women. We need to tell them what is menopause, because nobody tell us. I'm really upset because I've been in the UK and nobody teach me or tell me, nurse, doctor, about menopause. And I keep going to the doctor. I told him I feel my health no good, my energy getting down. He check, and paracetamol, ibuprofen, you fine. Special until now, when I go walking little bit, before I have lots of energy, I walk and I feel my heart getting quickly faster, and I have forget something. All this issue and suffering, I don't need anybody go same what I go through. All this, we are in the UK 2025, and menopause, we know, tell women we are have family, children, and we need somebody to look after us, yani, to teach us about these important things. It is really damaged me. Still now I have suffering, sorry, with my vagina. I go to the doctor and give me lots of different cream. Still, I have this itching, no sleep in the night. I go online and I buy cream. I feel much better than before. Look what they told me from the beginning. I can maybe easy to help myself with the doctor, with the nurse, how to look after myself. We need to do lots of things to talk the GP, early talk with the lady, or to do group and different language to help women because they struggle with the English. Thank you.
It's interesting, Lubna. So I think you've got opportunities as healthcare professionals to open up the menopause conversation, because lots of women we see in menopause, we may not have seen them for 20 years since they've had their children. We've got opportunities when they attend for their cervical screening. We've got opportunities when they attend for their over 40s health check. We ran a study day in Oxfordshire a couple of weeks ago that was sold out, with nearly 200 county-wide and beyond healthcare professionals, ranging from nurses right through to consultant gynecologists, who attended just to improve their awareness and knowledge about lots of different women's health conditions. And I think the difficulty is often targeting the ones who need the education most and perhaps don't engage with the learning episode. So hopefully by educating some, they go off into the practices and share their learning. But I agree with you. I think the education needs to start early. I think schools is where we should start the conversation, and it needs to continue.
Yeah. And another things, I keep tell my husband, my family, I have menopause. They laughing. They don't know about menopause. They don't know me. I don't know how about them. I told them I learn now. Go and search and find. I have menopause because I sometimes reaction. I'm shouting and I keep sit down. Why I'm shouting? And until I learn this is from menopause, and I keep tell them I have menopause. Menopause. They keep laughing. They still no understand what's going on. What is the menopause? My children and my husband.
Yeah, and there's a lot of education and outreach still to do, isn't there? And that's something that we can all do in our communities or in our workplaces. And as Healthwatch Oxfordshire, because we've heard so much about menopause over the last year, we've put together a flyer with information about what we heard and also what is menopause and where to get support. So we'll be sharing that. And we'll be putting this webinar online. I'll just put the link in the chat, but it will be on that webpage webinar. So please do share the recording with people who couldn't be here today. So it just remains for me to thank you so much, Lubna, Fatu and Katie. Really, really interesting and useful session. And I hope you'll have a lovely rest of your day.
Thanks.
Thanks for having me.
Take care.